In the previous lecture, we focused on normal age-related changes to the body. These were changes that reflect the natural biological process of aging and that most people will experience, albeit at different rates and in different ways. But now, we're going to shift our attention more specifically to pathological aging. Pathological aging refers to the presence of chronic conditions, disease processes, or impairments that go beyond what is considered normal aging. It's important to emphasize right away that while the risk of disease increases with age, disease is not an inevitable outcome of aging. We may be at a heightened risk of developing certain diseases or disorders as we age into older adulthood, but many older adults age without developing any major pathology. At the same time, others may experience multiple chronic conditions that significantly affect health, functioning, and quality of life. Understanding the difference between normal aging and pathological aging is essential for all players in a healthcare system, as it helps contribute to accurate diagnosis, appropriate care, ethical decision-making, and effective system design.
That's where I'll spend it
It is sometimes easy to misinterpret pathology as a normal part of the aging process, as many confuse certain diseases and disorders as simple consequences of getting older. However, confusing normal aging with disease or assuming disease is simply a normal part of getting older has real consequences. When pathological aging is dismissed as normal aging, conditions may go undiagnosed or undertreated. Conversely, when normal aging is mistaken for disease, older adults may be over-medicalized, subjected to unnecessary tests or interventions, or viewed as inherently frail or incapable. From a gerontological perspective, this distinction is also deeply connected to ageism. Treating aging itself as pathology reinforces stereotypes that older adults are inevitably sick, dependent, or declining. This distinction also ties directly back to ideas we discussed in the first module of this course, particularly successful aging. If aging is framed as inherently pathological, successful aging becomes an unrealistic or exclusionary concept. But when we recognize that disease is not inevitable and that adaptation and quality of life are possible even in the presence of chronic conditions, successful aging becomes more inclusive and meaningful. One defining feature of pathological aging in later life is multimorbidity, which refers to the presence of two or more chronic conditions at the same time. Multimorbidity becomes increasingly common with age, particularly among adults in their late 70s, 80s, and beyond. Multimorbidity means someone is living with interacting conditions that can complicate treatment, increase care needs, and affect daily functioning. From a gerontological standpoint, this complexity challenges healthcare systems that are often organized around treating single diseases in isolation. As just discussed, though, multimorbidity means that a person is experiencing multiple issues that may also be informing or interacting with one another. This means that successful treatment of the whole patient may require dedicated efforts to treat multiple issues in tandem, recognizing that changes in one diagnosis can impact another. Multimorbidity also highlights why functional status and quality of life often matter more than disease counts alone, as successful treatments of the whole patient must account for assuring that the older person walks away happy and secure rather than simply devoid of disease. Let's now turn our attention to some of the more prevalent chronic conditions experienced by older adults. Cardiovascular conditions are among the most prevalent examples of pathological aging, with common conditions including hypertension, coronary artery disease, heart failure, and stroke. While we discussed normal cardiovascular aging in the previous lectures, such as reduced vessel elasticity, pathological cardiovascular conditions involve structural damage, impaired blood flow, or functional decline that exceeds typical age-related change. The risk of these conditions increases with age, but they are also strongly influenced by modifiable factors such as physical activity, diet, smoking, stress, and access to healthcare. Social determinants of health play a significant role in shaping who develops cardiovascular disease and how well it is managed. From a gerontological lens, cardiovascular pathology affects not only survival, but also independence, cognitive function, and overall quality of life.
You can pass it.
Pathological aging also commonly affects the musculoskeletal system, particularly through conditions that compromise mobility and increase vulnerability to injury. Key conditions include osteoarthritis, which involves joint degeneration and chronic pain, osteoporosis, characterized by reduced bone density and increased fracture risk, and frailty, a clinical syndrome marked by weakness, weight loss, fatigue, and reduced resilience. While some decline in strength and flexibility is normal with age, pathological conditions significantly increase the risk of falls, disability, and loss of independence. These conditions highlight an important gerontological point. Pathology often becomes most impactful when it intersects with environmental factors, such as unsafe housing, lack of transportation, or limited access to rehabilitative services. These themes will arise time and time again throughout this course.
You can pass it.
Metabolic and endocrine conditions, particularly type 2 diabetes, are also common in later life. Diabetes involves impaired glucose regulation and is associated with increased risk of cardiovascular disease, kidney disease, vision loss, and nerve damage. Diabetes comes in two types. Type 1 diabetes is an autoimmune condition where the body stops making insulin, requiring daily insulin for survival. While type 2 diabetes is characterized by insulin resistance and insufficient insulin production, making it more common and often preventable. Type 1 diabetes typically develops in childhood or young adulthood, but can occur at any age, whereas type 2 diabetes is more common in people over 40, though it is increasingly seen in younger people. Although age increases risk of developing diabetes, it is strongly shaped by lifelong patterns of nutrition, physical activity, stress exposure, and healthcare access. From a systems perspective, managing metabolic and endocrine conditions like diabetes in older adults often requires balancing treatment goals with quality of life, functional status, and comorbid conditions. As an example, an older adult may present with a metabolic issue wherein the standard of care involves a treatment that would significantly diminish their quality of life. In this way, it may make sense for the person's care team to consider alternate forms of treatment which have less of an impact on the patient's quality of life, thus promoting both their health and their sense of happiness. This reinforces the importance of gerontologically informed care.
You can pass it.
Pathological aging also includes neurological and neurodegenerative conditions, which are often among the most feared aspects of aging. We will revisit this topic in the next module, but we'll briefly address it here as well. Some of the more well known and feared neurological and neurodegenerative conditions include dementia, including Alzheimer's disease, Parkinson's disease, and cognitive impairment following stroke or other neurological injury. It is critical to distinguish these conditions from normal cognitive aging, which we discussed previously. Mild changes in processing speed or reaction time are not the same as neurodegenerative disease. The increasing prevalence of dementia with age underscores the importance of early recognition, supportive care, and ethical decision making. Topics we will again explore more deeply in later modules, particularly those focused on psychological aging, communication, and ethics.
You can pass it.
In pathological aging, sensory changes may progress beyond normal decline into significant impairment, such as severe vision or hearing loss that interferes with daily functioning. Functional impairment, difficulty performing activities of daily living, often emerges from the interaction between pathology, environment, and social support. Importantly, disability is not solely a result of disease, but of how well systems accommodate changing needs. This reinforces a key gerontological insight. Pathology does not automatically determine outcomes. Supports, adaptations, and policies matter, and thus should be at the forefront of a healthcare administrator's thought process when supervising a healthcare system with elder clientele.
You better. That's it.
The oldest old, typically defined as adults age 85 and older, experience the highest prevalence of pathological aging. This group is more likely to live with multiple chronic conditions, frailty, functional dependence, and cognitive impairment. At the same time, the oldest old also exhibit tremendous heterogeneity. Some remain highly functional and independent, while others require extensive support. This variability ties back to debates around compression versus expansion of morbidity, which asks the question: as life expectancy increases, are we living longer with prolonged illness or living longer with disease concentrated near the end of life? Evidence thus far seems to favor the latter, although the jury is still out and may be dependent on individual histories and experiences. Regardless, understanding this distinction is critical for planning healthcare systems, long term services, and caregiving supports.
You better. That's it.
While age itself is a risk factor for pathological aging, it is far from the only one. Non modifiable factors include genetics and biological aging processes. However, modifiable and structural factors play a substantial role, including physical activity, nutrition, socioeconomic status, environmental exposures, access to preventative and ongoing healthcare, and lifetime exposure to stress and discrimination. This reinforces the life course perspective introduced in Module 1. Pathological aging often reflects cumulative advantage or disadvantage across decades. It isn't just about experiences and choices made in later life, but also earlier in life too. The presence of such modifiable factors also complicates simplistic notions of successful aging. From a gerontological standpoint, successful aging cannot be defined solely by the absence of disease, but must account for adaptation, support, dignity, and quality of life.
You better. That's it.
Pathological aging presents significant challenges and opportunities for healthcare systems and administrators. Key implications include a shift from cure-focused models to management and support, the need for interdisciplinary care teams, improved care coordination across settings, greater support for family caregivers, and policies that address both medical and social needs. For healthcare administrators, understanding pathological aging is essential for designing systems that can respond to complexity while promoting equity and person-centered care.
You better. That's it.
To conclude, pathological aging involves disease processes that are not inherent to aging itself, even though their risk increases with age. Distinguishing pathology from normal aging allows us to provide better care, reduce ageism, and design more responsive systems. This lecture, together with the previous two, highlights a central gerontological insight. Aging is shaped by biology, but outcomes are shaped by context, support, and systems. As we move forward in the course, we'll continue to build on these ideas as we explore psychological aging, communication, ethics, and policy, always returning to the question of how we can promote health, equity, and quality of life in later years. As you reflect on this material, consider this question: how might redefining successful aging to include adaptation and support, rather than the absence of disease, change how systems care for older adults? This concludes the third and final lecture in Module 2. If you have any questions about the material covered in this lecture, please contact your instructor for this course. Thanks for watching.
That's it. That's it. I'll spend it, baby.